of medicine. I may invite our first speaker, Professor Christina Puchansky.
Thank you very much for the lovely introduction, and it's a real pleasure to be here. So let me see if I can get my slides going. There we go. Okay. All right. Are the slides visible? Yeah?
Yes.
Okay. So I'm going to do a brief overview of spiritual care as a clinical discipline. And I know we talked about medicine in the title, but it's actually interdisciplinary. And as you'll see from some of this presentation, I was reflecting as I was preparing for this talk around spiritual care, and it's really nothing brand new, actually. Within palliative care, Cecily Saunders talked about the term of total pain. So physical, psychosocial, and spiritual pain. So she described that as an essential part of how we care for people with serious illness. And then in the whole person care model for years, and complementary and alternative medicine practitioners have talked again about the whole person, addressing all domains. Many of you probably are aware of the WHO Palliative Care Resolution, which is the first time that the word spiritual is mentioned anywhere in any WHO documents, but I was involved in that, and there was quite a bit of debate, and yet it really was recognized that we have to attend to palliative care is the approach that improves the quality of life through the prevention and relief of suffering by early identification, assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. Within the US, spiritual care professionals, well, spiritual care has been going on long before, for many centuries, but with regard to healthcare, at least in the US, since the early 1900s, chaplains, healthcare chaplains were practicing in healthcare settings. The field looks very different now, but it was certainly part of the care that patients could receive, mostly within a religious context, but nonetheless, a recognition that that's important in healthcare. And yet there's continued to be a divide between clinical care models and professional spiritual care. And a lot of our work at the George Washington Institute for Spirituality and Health is to bridge that divide by creating clinical models and ways to address spiritual distress and spiritual health. So, and while we are doing it, we have been doing it predominantly in palliative care. Palliative care is increasingly seen as working with patients who have serious chronic and other illnesses besides, and as well as dying. So it applies to all of care. And more recently, our new dean, our first woman dean, Barbara Bass, has expressed the interest in spiritual health. And how do we not just only talk about it as distress, but also as spiritual health, which is a way that we've been focusing on more recently. Now, everybody's talking about COVID, and in particular, from my perspective and from many people's perspective in spiritual care, the pandemic has really cast light on the critical need for spiritual care. And if we think about what everybody globally, all of us today, my neighbors, family members, people around the world, is that it's a time of uncertainty. We don't really know exactly what the future holds with this pandemic. And that triggers reflection, a lot of reflection. There's isolation, loss, grief. Facing mortality raises many deep spiritual and existential questions. And so people are recognizing that element. In my own clinical setting, for the first time, and GWISH has been around for over 20 years, and I've been working there a little longer than that. For the first time, people are saying this is such a critical need. And think about what happens in the clinical settings. You know, Dr. Zitter and I were just talking about what is going on in California, what's been going on in New York earlier in the early part of the pandemic, huge what's going on across the country and in the world, increased numbers of cases, more and more people who are dying from this illness and having to face really difficult choices. So what happens to clinicians in this setting? I know in my, I work in the outpatient setting. My colleagues who are working inpatient from the very beginning of the pandemic have said, there's nothing really that I can do. There's nothing I can do. We don't have any known treatments. I mean, now it's a little bit different, but that experience of inadequacy and not being able to fix, which is so much a part of our training. But I think what has happened is the experience of the power of presence and the experience of the power of compassion, particularly in the face of uncertainty. Now, all of these things that patients are facing now in COVID is magnified because of the numbers, but this is what people go through when they have serious illness or when they're struck by loss or grief. And that need to be able to recognize that that can result in spiritual distress, and in our duty to be able to address that. Just to put up a slide, that this is before the pandemic, there have been many studies that have shown the frequency of spiritual distress in patients in many parts of the world, and these studies continue to occur. So I want to talk about a patient who I'm going to call Mike. And while some of the details are changed, this was a real patient of mine. He actually was the first person, the patient that I saw in telehealth. So try to picture myself being nervous with how does telehealth even work, the mechanics, the technique, and then being present to someone who is suffering. So the story of Mike is that he experienced a real traumatic relationship in another state, and at the same time was beginning to experience difficulty with his memory, shaking, having a lot of workups, not knowing what was going on. So he moved here at the beginning of the pandemic, a little bit before, but then the pandemic hit, to be with his family, his daughters and his son who live in the area. And now I'm seeing him in the middle of the pandemic. This is not his real picture, but he's isolated in his apartment. His daughter has joined in by Zoom, so we are having a three-way conversation, and he's telling me the story of that pain, of what that meant to him, of how devastated he was. A beautiful man. He raised his family on his own after his first wife left and abandoned the family. She had drug addiction problems, very devoted to his children, a highly successful person. For now, everything, all of that has been taken away from him. So in his spiritual history, in taking a spiritual history with him, he talked about it as more personal, as a source of his moral compass. His meaning is in family and raising his children from the beginning and being that father, continuing to be that father for his family. Wondering what he will do now with whatever time is left in his life. Tremendous amount of uncertainty, very isolated. I came here to be with my family and I'm sitting here alone in my apartment. He talks about his spirituality, his faith is very important, and that it does impact how he deals with his stress. But then in the midst of the spiritual history, I started to talk a little bit about goals of care, and which I like to do within the context of spirituality. And he said, I wonder if I'm really good enough in God's eyes. If I die from all of this, will God see me as a good man? And, in that moment, of course, I wanted to say everything you've just shared to me points to that. I didn't. I sat in silence with him as he shared his profound grief and sadness and loss, and his own sense of who he was being eroded, and grappling for any lifeline that would help him in this moment. That silence went on for I don't know how long, but I learned so much about that suffering that he was going through, and I also learned that it could not be fixed, as I experienced with all my patients. That my being present and holding that space for him was the best that I could do at that moment to learn about what was really going on with him. As we progressed, and I'll share later what actually happened with him, he was his community was family and like-minded friends were as well, but he was isolated. He was willing to see a chaplain if we could find someone who could do that by Zoom, which was a challenge at the beginning. So what is spiritual care from the perspective, I think from all of our perspectives, but certainly from the perspective in clinical care? It is at the core of respectful, compassionate care. That's what spiritual care is. By understanding what gives patient meaning, purpose, and hope, we can provide a critical role in helping to relieve suffering for people and their families in our care. By being present and accompanying patients, we can help alleviate suffering. And while these words are relatively easy and straightforward to write, this is not that easy to practice. As I partnered with my colleagues. I chose to be very intentional with one of my colleagues in geriatrics and palliative care, and we texted every single day what was going on, her anger, her sadness, her feeling impotent, what she could do. It's very, very difficult to witness the extreme suffering. And so much of our training is about how can we help people witness without trying to fix, witness without, as it's beautiful, a chaplain wrote a beautiful article, which was published in a section I co-edit in Journal of Symptom and Palliative Care. She was really, really struggling with how to attend to a patient who had COVID, who was dying. And one of her struggles was, how can I be present in this moment when I too am terrified of getting the virus, of all this paraphernalia I have to wear? How can I be present? So creating models, I think, has been really important to doing this, to bringing spiritual care into the clinical model. And spiritual care, I believe, is the way to operationalize compassionate care. Catherine Pettis, who has written beautiful work and a beautiful article on the need to operationalize compassionate care, I think the way to do that is through spiritual care. In developing models, we developed a broad definition of spirituality. It's very inclusive. This is a globally based, consensus-based definition, but everybody has a spirituality, whether it's practiced in the context of their religion, culture, humanism, secular humanism, etc. And key to this model that many of you have probably seen already is the generalist specialist model of care, that everybody on the team who attends to patients is responsible for addressing spiritual issues. But we recognize the spiritual care professionals as the experts and one we need to work with closely. And so assessment, diagnosis, and treatment of distress, identification of resources, those are our roles as clinicians. But again, in providing compassionate care, working integrally and side by side with chaplains is key. And that is a challenge in the States, and probably in other areas where there are no chaplains even trained or available widespread. Same in our country. We need more chaplains and more spiritual care professionals in both in and outpatient settings. The National Consensus Projects in the US on palliative care, Domain 5 is the spiritual care domain, and it's recognized as an essential component. Spiritual care service, including screening, history, and assessment, is performed at admission and regularly thereafter, and interventions should use professional centers of practice. That's for all of us, professional spiritual care providers as well as ourselves. We have published, and this is based on the National Cancer Comprehensive Network, spiritual distress diagnoses that we're currently working with right now in terms of developing ways to understand more what is the spiritual distress and how to treat it. And in terms of assessment, just a work that was done with Tracy Baboni and colleagues, I was part of this group, just surveying palliative care providers on how people communicate. So screening is brief. History taking, which is the FICA tool, among others, is a more detailed one that clinicians do. And the full assessment is the one that trained spiritual care professionals and chaplains do. So at the bedside, we should do a FICO or some other type of history to assess for distress as well as resources of strength. Offering compassionate presence is a key part of the spiritual care that all of us should offer. We include beliefs and goals, values and goals of care, and document resources in the chart, and always ensure the dignity of all of the patient and the family, and refer to spiritual care professionals. And this is a brief we did for global organizations in palliative care for spiritual care in palliative care during COVID. Now, what about chaplains and spiritual care professionals? It'll be interesting to hear from some of you about some of the different ways and standards, but in terms of what we've worked with, our chaplains have taught us in the US and working also in part globally, is that the board certified chaplains can confirm or change whatever our diagnosis is of spiritual distress and the type of distress. Chaplains are trained in very different counseling skills and listening skills than we are, so they can go deeper. They can do the appropriate interventions, but also recommend what type of interventions we might do. So healing in relationship is core to spiritual care. Compassionate listening and presence is just as important as this more reductionistic assessing, diagnosing, putting it into the chart. And one of my favorite quotes is from Henry Nouwen about listening as a form of spiritual hospitality by which you invite strangers to be friends, to get to know their inner selves more fully, and even dare to be silent with you. Silence is such a profound intervention. And as I've learned over the year, it is possible in telehealth as it is in person. So getting back to Mike, I did a review of systems just like any other clinician would do, but I've added the spiritual review of systems to my review of systems. And in his case, there was grief, loss, profound, concern about his relationship with God, existential distress, fear of uncertainty about his health and death, and what will happen, especially in this time. And so an example of charting. And interestingly, in much of our work, our colleagues do the history and they do the assessment, but charting is our next challenge. It's hard to do that in clinical records. And so we're working on ways to do that. But the chart is the way that we communicate. If it's not in the chart, it's not seen as an important part of care. So just in closing, we have developed an interprofessional spiritual care education program with my colleague Betty Farrell at City of Hope. Betty Farrell is a major global nurse leader in end-of-life and palliative care and nursing education and research, and a privilege for me to collaborate with her in this endeavor. And we've designed this in a way as an online course, a train the trainer, and then working with institutions. And we've intentionally invited spiritual care professionals, chaplain, clinician pairs to many of these programs. Since 2018, we've had 251 participants, 25 countries, and 26 states that have been involved. And just want to share a quote from one of my medical students who took the online course as part of our training. And what he says is, I found ISPEC to be incredibly inspiring. I felt chills and familiarity with the motivations I brought into medical school. What has happened since starting medical school is an extensive focus on a technical and not enough focus on the sacred aspects of medicine. I look forward to putting these principles into practice. I intend to take a pause moment before seeing each patient so as to center myself and become prepared for the sacredness of the encounter to come. And that is what is so critical and what spiritual care does. It raises the awareness to the sacredness, to the holy, to the significant that is in every encounter, whether it is end of life, whether there's a new visit, whether it's at the time of childbirth. These are the sacred moments, and these are the opportunities for healing for our patients, for their families, and even for ourselves as healthcare professionals. So thank you for your attention, and I look forward to our discussion later on this afternoon.
Thank you so very much, Christina. Thank you so much, and I'm glad we have time afterwards for questions, for discussions, for experiences to share with each other. I may now invite our second speaker, Dr. Jessica Zitter. She will be interviewed today by Dr. Pamela Cooper-White, our president, and we'll move on. Thank you.
Thank you, Claudia. Jessica, are you unmuted? I can't see you on my screen at the moment.
I'm unmuted.
There she is. Okay.
Can you hear me?
Yes. Very good. Perfect. So I first met Jessica about a year and a half ago, I think it was, when she was the plenary speaker for an event at Jewish Theological Seminary that was part of a larger, I hesitate to call it a festival, but it really kind of was like a film festival. It was a series of events taking place all across New York and all across San Francisco the same week, around the week of Halloween or All Souls. And it was called Reimagine Death and Dying. And so Jessica shared her amazing work in palliative care, and I had the great fortune of being the moderator of that panel, and so we got to know each other then, and I wanted to bring her on board for this conversation. Like Christina, she is a doctor who has become, over the years, convicted and immersed in the need for compassionate care. And so I'd like to just ask you, Jessica, to begin by telling us just a little bit more about yourself, and in particular, what was the pathway that got you from your medical career into palliative and compassionate care?
Well, it's, just listening to, thank you so much, Dr. Prochalski, for that beautiful talk. Listening to what Max said gave me chills, because I remember that I came into medicine thinking that I was coming into a profession where I could actually connect with people and help them. And before I knew it, I was in this, I would say I was on my own conveyor belt to becoming a specialist. In my residency program, there were 60 people, and 57 of them became specialists. And by the way, of the 3 who went into primary care, 1 eventually became a gastroenterologist. So that was the expectation, in a way. You go to these programs, and the more interventionalist you can become, the better doctor you are perceived to be. It's almost subconscious. We call it almost a hidden curriculum. It's part of this hidden curriculum. And I just kind of, being a good soldier, I kept moving forward on that. And the next thing I knew, I was an ICU doctor. And I was all about interventions and machines. And in some ways, I have to say, in those early days, it was a relief, because I was witnessing so much suffering. And I had knobs and tubes and catheters to hide behind. And that's what I did. And it numbed me, because I didn't know how to process the suffering I was seeing. And so what happened to me was that in those early years of being an ICU doctor, in 2003, it was really my first real job. I was working at University Hospital in New Jersey in the ICU. And there was this tiny little pre-palliative care team. They didn't even call themselves the palliative care team. They called themselves the family support team, because who knew what palliative care was? And it was led by a nurse named Pat Murphy, who did not suffer fools and who was very palliative minded, had trained with Elizabeth Kubler-Ross. And she had won this incredible award that came from the Robert Wood Johnson Foundation to enhance communication in the intensive care unit. And suddenly, she was all over the ICU. And I didn't know who she was. I didn't know what she was doing. She was talking to my patients. That wasn't the way it worked in the hierarchy. The ICU doctor was the boss. And here she is, and she and her people are walking around. and she was telling me things that I didn't want to hear. Like, hey, wait a minute. Does that patient in room 7 know what you and I both know, that they're not going to survive? Have you even told them? Does that patient in room 5 who's writhing in pain, have you even thought about starting pain medications? And over time, she I was at first very defensive. And then eventually one day, when I was putting in a Quinton catheter into someone's neck who was dying, I realized, and she came and said, she pretended that she was on the phone saying they're torturing a patient in the ICU. That was my epiphany moment. And I broke down my defenses and my place on that hierarchy. And I felt a humility. At first, it was shame and guilt, because I knew all of this stuff came rushing in. I had once been Max too, by the way. And I realized I had gotten off my path. And I, within a few days, went to Pat and I said, I need you to help me. And that's when I started to learn about palliative medicine. And it took me many years to get to a place where I could really feel good about my practice of medicine. And it was palliative medicine that led me there. So I thank it. I guess, is that answering your question?
Yes. I would like to actually share with everybody just a little over 1 minute clip, a trailer for your now award-winning and wonderful film documentary called Extremis. And let me get this up. Okay. So I hope you can all hear this.
Selena, can you squeeze my hand?
Here's the reality. We're all going to die. Everyone standing in this room is going to die one day. And it's good to have A little bit of a say in how.
I want to make sure that she knows that we've explored all the options.
Every day, people are attached permanently to machines. My concern is we're going to cause more suffering without likely benefit. The other approach is let her pass naturally.
It would feel like murder to pull her life support.
If I had to make the decision for myself, then take me off, and if I breathe on my own, then that's fine. That's God's will.
Amen.
How would you feel if you were not getting better on a breathing machine?
Then I don't want to be on a breathing machine.
It's his decision, but I don't want to see him go.
We're going to support you through this. Pull the crash cart in. She won't wake up from this in a meaningful way.
Family?
Knowing at some point you got to get to that reality, and now it's here.
Okay, so talk a little bit about the making of that film and your relationship with the spiritual care team, the chaplains, as you were involved in what you were showing us there in that film.
Well, that film, the suffering that I described to you, and my opening to it, after Pat saved me and showed me a new way, it's powerful stuff. Dr. Prochalski and I both spend our careers facing suffering, facing spiritual distress and spiritual suffering and physical suffering. And it's very painful to watch. A lot of it is avoidable. In fact, I would say much of it is avoidable. The hospital system is not set up to mitigate it. In fact, it exacerbates it. We are completely separated. In fact, we think as doctors that we should separate ourselves from people's spiritual positions and spiritual selves because we don't think it's scientific. And so we are causing more and more distress on top of the existential distress of serious illness and death. And so I started to write about it. I was always a writer since I was 11 with my little journal, but I really started to write about it. And I felt that it was important to share it with my physician colleagues. And I specifically talk about physicians because I think that other healthcare professions are frankly doing a better job. I feel that I have a lot of messaging that I want to do to my fellow physicians about this suffering, both for our patients and for us. And so I started writing, and I was writing for lay audience as well. And people really wanted to hear more. And I felt that this was a way to justice, a way to repair some of the, by raising awareness about what this is and about the fact that there's another way to do it. I wanted to show people a new way. And then one day I saw a film that was made in our hospital about being in the emergency room. It was a different issue about access to healthcare. And we had a big screening in our community. And I went up to the director and I said, you need to come in and do a film about what happens in the intensive care unit, the decision-making, the fact that people end up there without any preparation. And this filmmaker, I just kept texting him for about 1.5 years and bugging him every time I had a conversation that I thought would be important for the public to see. And finally, he referred me to another filmmaker who came in and made the film. With me in his ear constantly sort of giving that perspective, because this is not something that the lay community knows anything about. A filmmaker wouldn't know about all of these issues that are going on in a hospital environment, all of the issues that are going on in a physician, and the rigidity and the difficulty that we have in reaching towards our patients. So this is, that's how Extremis came to be. And there was a second part of your question, which was about spiritual care. And I want to say something because I'm speaking to the converted. My first mentor as a doctor was a nurse named Pat Murphy. My second mentor was a woman named Betty Clark, Chaplain Betty Clark, who I have worked with now for 10 years at Highland Hospital, and who has taught me the second bunch of everything I know, and has really warmly guided me with all of my naivete into this new world of being able to be a little bit more competent at obtaining a spiritual history, at thinking about people as spiritual beings, and taught me really everything I know on that level. So I just have to say, you are all doing important work. And I feel that it is my mission to bring my colleagues, my ICU colleagues, my oncologist colleagues, et cetera, into an understanding of how critically important it is to have that next team member be the spiritual care, whether it's the hospital chaplain or the community faith leader, who is so critically important and who we exclude and we don't even think about. And so we've got a lot of work to do.
You mentioned Highland Hospital. I know that that's in Oakland, and a very large proportion of patients there are African-American and Latinx. And last summer, you wrote an op-ed for the New York Times on the racial disparities in medical care. And I wonder if that also entails some particular disparities, or I think you called it a polarity, between the faith of the patient and the doctor's typical attitude toward faith, coming from a more, having been formed to be more scientific in approach. And so can you talk a little bit about that disparity, especially involving also how you address justice issues, especially for communities of color?
Oh, big, huge topic that could take a whole 8, 10, 12 weeks, months, hours, etc. If you really want to be reductionist, and sometimes I think it's helpful to think about spirituality is one variable of personhood. There's so many of them, right? And race obviously is one, and educational, so many things that come into a person's experience in life and then that they bring with them into the hospital. And what I would say is that it's so easy for us, the physicians who are all ourselves on this conveyor belt and ourselves trying to manage a lot of suffering and distress. We do that thing. We have these incredible we bucket people so that we can just push things through the system in order to get through the day. I'm not, and what we do is, again, so damaging. It's this, whether it's about race, whether it's about if a person's a spiritual person or not, whether a person speaks English, we make decisions and assumptions about that person in milliseconds, and it informs how we treat them. And it was interesting because I'm doing some work with an amazing group called the Alameda County Care Alliance here, based in Oakland, which is a group that is based on faith-based African-American communities, trying to support them to achieve equal access to good end-of-life care. And we're working on a project to educate faith leaders using the film Extremis, because the film Extremis mostly has African-American patients in it. And it's a relatable film for an African-American community. And so that is work that we should talk about separately. In fact, Dr. Pachalski, I'd love to tell you more about it, because I think it's a model for a new way of integrating faith leaders in the community with healthcare staff and really bringing people together in a more therapeutic way for everybody. But the reason I'm telling you about this now is because of the comment that she made to me, Cynthia Perliot, who is the executive director of this group. And she's an amazing woman and friend of mine. And she said, I just want to ask you, in one of our deep moments having coffee together, she said, can you tell me if when you hear that somebody is a person of faith, that they believe in God, does it make you think they're less intelligent? And I just thought that question was so telling, that she who has her life's work is focused around supporting communities of faith is wondering whether or not medical communities somehow look down on that. And I'm sort of rambling here, but I guess what I'm saying is that obviously my answer is no, but I hate to say that I think for some doctors, and I am blaming doctors a lot, but it's an easy reductionistic way to talk about this. Yes, when people hear that somebody is a person of faith, there is some assumptions that are made about what they're going to want, what kind of end of life care they're going to want. And yes, part of it has to do with race. And there's this disconnection that happens. You make this decision in your head. Oh, this is a person who wants everything. Oh, this person believes in miracles. It's not even worth engaging in a conversation about goals of care. It happens all the time. And so just hearing her ask it, that she perceived this as this person who works at the intersection of these two worlds all the time, it's heartbreaking. And it's true on some level, and it has to be remedied because we are all here knowing that it is overly simplistic and causing tremendous pain and suffering.
It strikes me that you're addressing different levels or forms of implicit bias that people are not even conscious of and might consciously disavow, but also the nature of intersectionality, which, that term gets watered down to just mean, well, we have lots of different aspects to ourselves, but it came out of the battered women's movement, and it actually means people who are experiencing multiple forms of oppression simultaneously. And it strikes me that you're pointing to adding, sort of writing somebody off if they are too religious as another form of implicit bias to pile on top of race and gender and sexuality and all kinds of other ways in which they can be viewed as less than by doctors who've been educated in a particular system.
Beautifully said. I mean, I couldn't have said it better myself. That's exactly what I'm saying. Yes.
Just last week, we had our first graduate from our Doctor of Ministry program, which is for chaplain supervisors. And this gentleman, who is himself African-American, works in a community hospital in West Philly, used a term I'd never heard before, miracle literacy. And I think you and I talked a little bit about that when we had our conversation. Can you say a little bit more about the miracle piece for doctors when that comes up?
Yeah. It's shorthand for us. It's, the patient in bed 5 believes in miracles. I've probably had that sign out when you're getting sign out from somebody else. Okay, here's my list of 7 people that I have to take care of going forward. And I think it's shorthand. That word triggers something in a person in a doctor. They believe in miracles. It means don't even begin to try to talk to them about the fact that this person actually may die. And that maybe the limits of what a human physician could do right now are just actually going to be adding suffering. So I think it's the word miracle somehow, and there's other words too, but there's something about the word miracle that just turns people off from engaging, and it's a real problem. Because I will tell you one example, and I'm putting myself in this group. We were having this incredible experience. We brought Extremis to this group of faith leaders in Oakland. We watched Extremis. We talked about the end-of-life conveyor belt. There was this incredible, I was there with mostly African-American leaders as well. So there was a sense of trust, even though I'm white, which sometimes is a problem. This white doctor coming and talking to us about potentially withdrawing or withholding life-limiting treatments and technology, that could raise suspicion. So it was this very productive conversation. I felt like I was helping people. And one of the pastors came up to me afterwards and said, "Thank you so much. This was incredibly enlightening for me. I really appreciate learning a little bit more about what those machines are in the intensive care unit and what the limitations are of them. And this was really helpful. And it reminds me of a time that I was with my mother and we went through this thing." And then he said, "And we had this experience and we prayed for a miracle." And I got confused because I thought he and I had this conversation where we had acknowledged that sometimes we can't create a miracle of life-saving. So I assumed that what he was telling me was that with prayer, we still can. And I said to him, "Wait, I just want to make sure I understand. Were you talking about the miracle that she would continue to live if we kept?" And he said, "No." He looked at me like I was nuts. He said, talked about the fact that that was not possible. It was the miracle of reconciliation and of spiritual triumph. And I realized I had again made this mistake of assuming that this man who had just gone through this whole big reflective conversation with me was telling me when he used the word miracle that somehow we can still triumph by continuing to fight on with machinery. And that's not what he was saying at all.
Yeah, sometimes death is the healing and the wholeness that's needed for a family and for the individual. We've only got time for a couple more questions, but one of my questions for you is you've talked about how you used to back out of the room when the chaplain would start to pray, and you no longer do that. Can you say a little bit, just briefly, about your own shift when it came to praying with patients?
Yeah. Well, I'm Jewish, and I'm some days I believe in a God, and some days I'm feeling agnostic, and I'm very obviously religiously connected to my community. But I just felt that somehow I used the excuse in my own head that somehow it was inappropriate for me to stay in the room with Chaplain Betty when she would start praying with African American patients. It was a type of prayer that I didn't do. I consider, we Jews are more silent prayers. We don't, and I just felt like I wasn't supposed to be there. And frankly, I was uncomfortable. And Betty one day just put her hand on my arm and said, "We're going to pray now, Dr. Zitter." And I stayed. This was probably about 3 years ago, maybe 3.5 years ago. And I remember that moment. And I stayed in the room and I put my head down and she started to pray. And it was the most beautiful thing. It was a beautiful moment for me. And I never went back. I always, after that, looked for every opportunity to pray with my patients and their families. It was not only, it was just the sense of profound connection and profound healing that I didn't realize was even possible when there was no more life enhancing medical treatment that I could offer. But I just wish all of my colleagues could understand what it means, not only obviously to the patient, to have their physician stay in the room and want to join them in this important sacred moment, but what it means to them, how it can provide profound strength and relief from our own suffering at being witnesses to sadness and grief. So I again, one of my life's goals is to raise that awareness among my colleagues.
Both you and Christina have used the word witness, and I have loved that word for a long time. The Greek New Testament word for that is martus, which also is translated as martyr. And being present in that way is costly. It takes something out of your whole humanity. You're not just moving machines around or doing charting, but you're bringing yourself. And so you knew this question was coming. In just a couple more sentences, what is your definition of spiritual care?
Wow. Well, it really has a lot to do with what Dr. Puchalski mentioned, which is really being curious, asking questions, wondering about a person, asking them what makes them feel whole and supported, and really respecting it, really opening up your heart to whatever answer they might give you. Spending time with somebody. There's always time. I will tell you, as an ICU attending who has busy ICUs, there's always time. Even if it's 2 minutes of just silence and holding someone's hand, even if they're on a ventilator. It's an act of humanity it's why, like Max, I went into medicine. And it is profoundly powerful and important and humanizing for everybody.
Thank you for that beautiful answer. Thank you for being with us today, Jessica. And we're going to turn now to our small groups. So what I'm going to ask everybody to do is take a quick eye break away from the screen so that you can refocus somewhere at a distance, give yourself a chance to take a breath. We're going to be putting you in small groups for about 15 minutes, and that will happen automatically when I push a button. And if you want to, you can appoint someone to take notes. We're going to bring you back after 15 minutes. So if you can think together about what really struck you, what stood out to you, and comments and questions that you'd like to bring back to the whole discussion after we return. So what struck you? What are your comments and questions for our plenary discussion as we conclude after the small groups? So with that, I'm going to put everybody in breakout rooms. And all right, here we go. You'll need to accept the invitation to join your room. A few more people still need to join rooms. Julie, Ed, Morningstar. Okay. So those of you who are left here, we can chat a little bit. Jessica, Christina, Emmanuel, you want to unmute your audio, your video? That was great.
So fabulous. So great to hear, Dr. Pachalski. I loved.
Great to hear you too as well.
Yeah, and I thought, Christina, you really laid out some of the parameters and where the research has been, and then to hear kind of the testimony of another doctor who has been moving into this further and further and deeper. I thought that was very helpful and very informative. Oh, Edward is here. Edward is the DMin student I just mentioned, who. Hi, Edward. Congratulations, Dr. Peñate.
Oh, wow.
Yes. Yeah, Edward is in Chicago, and I actually said West Philly. I meant Chicago, and has been working with patients there and dealing with all of the COVID stuff, which has been very, very stressful. And appreciate you're bringing a new term to me, the miracle literacy. That was great.
Oh, is this who mentioned the miracle literacy to you? Edward?
Edward, yeah.
Oh, fabulous. Is that even a term in the literature?
Apparently it is.
Hi, everyone. My name is Edward Peñate. I am based out of Chicago at Northwestern Medicine. And so nice to join you.
And you're talking about medical literacy for chaplaincy training. Is that what you're talking about?
Miracle literacy.
Oh, miracle literacy.
So it's not found abundant in the literature, but it is what we called it. We've termed the miracle literacy piece for spirituality, spiritual care training with regard to palliative care fellows training, to raise awareness about the subjectivity of beliefs, but also how we face this in the context of clinical care, and especially in the area of palliative medicine, our fellows, our physicians, our teams do face these moments where families, patients are hoping for a miracle. And so part of, aside from building awareness, what we do with this subcurriculum of their training is to offer some frameworks and some practical tips on how to navigate these complex conversations. Yeah.
Yeah, Dan Macy wrote a beautiful article about, goals of care and discussions, particularly around miracles. And it's a very complex issue. And Jessica, when you said, that's been my experience for years. Miracle, that means they're going to be full code. So many assumptions. But I think, that there's some really complex things. And again, a reason for professional spiritual care to be part of those conversations, because, saying I believe in a miracle may be just a way of, I don't want to go deeper into the conversation around end of life. Or it may be a genuine belief there's so many complexities, and could be another sort of a denial. There's so many ranges, but that's why I think it's so critical that, yes, we as physicians and nurses should be aware of that, but working with people who are trained, especially in theology around, miracles and what that might mean for that person, and uncovering that. And also who don't have an agenda. Jessica, regardless of how, everybody knows how I feel when I'm covering in the unit, I have the MD agenda in people's eyes, right? Yep. So, it's really important for that collaborative work. Yeah,
absolutely. It reminds me a little bit about a patient that I had on Sunday who is 100% FiO2, COVID, terrible pneumonia, lying on a ventilator, prone. And when I was rounding on her, the team said, "Oh yeah, but her family, there's some nurses and some medical professionals in the family, and they want to know every little number and lab. They want to know the creatinine. They don't want to talk about, end of life." So it was the same type of bias about people who ask too many questions about numbers and labs. Oh, it's not even worth it. They just want you to be doing everything. And again, it's the same idea in a way. Miracles, well, you want to do something, continue doing everything. People who are asking too many questions, talking about too many numbers. But if you just open up a conversation with these people, most of the time, whoever they may be, most people are not, they're people who want to know information, and they're doing these, they're either talking about a miracle, or they're asking about data and labs, because it's a way to, I'm not even sure that I have an answer for why, but these are the judgments that the physicians taking care of them. And again, I should maybe say physicians and nurses, but I think it's more physicians. They just make these biased decisions, and you call family, and they're often just absolutely willing to have a conversation about what's going on. They just haven't had that opportunity yet.
Well, and to me, it sounds also like when so much is out of control, that there may be an idea that having all those numbers and lab reports is a way of having some control over the system. When you and I talked, Jessica, you talked about the power of doctors in the whole structure, and how that power can also harm.
Yes, absolutely. Absolutely. And I think that's why it's so important. The spiritual history is a model for any kind of communication, whether it's about talking about miracles, or it's about talking about why someone wants to know about every single data point and labs. If you just stop and ask people what they're hoping for and what they want, and obviously also get a spiritual history, but oftentimes the assumptions that we have made are completely wrong.
Yeah, and sort of on the other side of praying for a miracle, I've also had a number of international students. The ones who stand out in my mind both happen to come from India, but I think this is common in some other cultures as well, where it was absolutely taboo to tell a family member that they were dying, and that they would tell the whole medical team, don't tell grandma that she's dying. It will take away her hope. Yeah. And as it turned out in both cases, that the person all knew very well that she was dying. And it was finally the person who had to tell the family member, I know I'm dying. Can we talk about it? So far from asking for a miracle, it's almost like, don't disturb her in her last days by telling her she's going to die. And maybe she'll make some kind of a recovery.
Yeah. Yeah.
You know, I think this whole discussion also just keeps reminding me of, you know, we want to have everything so predictable and set. You know, I mean, my dad died at the beginning of the year. There was, I'm so totally open to things being unknown, you know, la, 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 la. But most people are not, you know, and we want some sort of prediction. And then in the hospital, we have Medicare and other little requirements of, you know, what are we going to do with this person? You know, are they occupying a bed? Are they not? I hate to be blunt.
Yeah.
Right?
Yeah.
So we have so much of that we can't let go of that train of thinking to this completely unknown world. I mean, I've had patients who lived, I mean, one person lived 10 years after I told the family for sure he had a few weeks, right?
Yeah.
So you just don't know whether you call it a miracle. It's just life is unknown and science has huge limitations, just like everything else. Right?
Absolutely. Yes, so much uncertainty. And the problem also is this idea of, I call it a thepkaison moment. I actually write about this in my book. It's a really important story of you're sure in your mind that someone is going to do badly and you're wrong. They either survive, which is rare, by the way. And I've polled many people. This is a rare thing when you're very, very confident that someone's going to have a bad outcome. And you're wrong, not even necessarily that they do well, but that they didn't do as badly as you predicted, or they didn't die as soon as you predicted. And for a physician brain, that is a moment of profound fear and shame, and you feel like you're giving up on them too quickly and you will never do it again. And I think having moments like that, which we all do if we're willing to come out and render a serious prognosis, is the risk is that you will then turn around and only talk about what we can continue to do in good prognoses. And I think it's really important that we accept the fact that there's uncertainty, and sometimes, rarely, somebody will do better than we thought they would. And it doesn't mean that we've done anything wrong. And it doesn't mean that the next patient who has a poor prognosis shouldn't learn that information as well.
How do you call this moment?
I called it my thepkaison moment. It's the name in the book that I gave for the patient who came in with a terrible, terrible brain bleed and was absolutely going to die. And I said to his wife, and they had 2 young babies, I said to his wife, I don't think you should go back to the neurosurgery suite, which is where the neurosurgeons were going to take him if he re-bled. And this guy was already, his brain was crushed against the side of his skull. And they ended up, I told her this, and she was pressured by the neurosurgeons. They took him to the surgical suite, and he survived. And then that was a moment of profound, just, oh my gosh, I should never give a bad prognosis, because if she had listened to me, he'd be dead. And I called her to follow up when I was writing my book and to find out how she was doing. And she said, he is miserable. He's a shell of himself. He drinks. He's can't move. He can't ride his Harley Davidson. And I think we made the wrong decision. And it's very complicated and nuanced, and you have to be willing to live with uncertainty as you render prognoses.
I'm thinking also
humility.
of
I think humility is a huge thing. And if COVID's teaching us lots of lessons. And here's another one. You know, we're functioning with very little data and, more hopefully, but still a lot of uncertainty. Yeah. And yet we're sort of doing the best we can. And that's really not that, I mean, it's certainly striking, but it's not at some fundamental level different. We do the best we can. Science is a belief system, but there's a whole lot we don't know. We just do the best we can. Yeah.
And in this little ICU that I was in on Sunday, where there's 7 patients who are all ventilated and all on 100% oxygen, many of whom are in their 80s and 90s, the likelihood that they will not survive is very great, and yet no one has really told their family. And that giving these families a prognosis that's probably likely that this person is not going to leave the hospital is really essential information, even though we're not 100% sure. It's tough.
Well, I had a doctor of ministry student in another institution years ago who actually wrote her whole project on truth telling, and it surrounded her sense of a dilemma as a pastor, where she thought the person ought to be told and the family didn't think the person ought to be told. And she felt like when she didn't tell the person that they were dying, that she was lying. And so it was a big dilemma for her to try to be both culturally sensitive and honoring the autonomy and the self-determination of the patient. But there are cultures where autonomy and self-determination are not as individualistic as we think they are in this country. And I was thinking too about the patient you describe in your New York Times op-ed about, I think it was there, where the patient's son took you aside outside the door and said, how do I know you're not just trying to save money by refusing to, or not wanting to ventilate him? And, you know, it intersects with culture, it intersects with race. And why would an African-American in this country think that the white medical establishment who experimented on people in Tuskegee and elsewhere would be trustworthy? Why would they think that? And we're seeing it now with the COVID vaccinations.
Absolutely. Even in my colleagues, by the way, some of my African-American colleagues who are very science-oriented are like, it took them a while to come around to it. They had to see a lot of their white colleagues getting vaccinated. But I think that's exactly right. There is no reason why an African-American who has witnessed the history and experienced the history of our healthcare system and our nation would feel trust in recommendations that we might make. And the only thing, there are several things I think that can be helpful, which include having a diverse team, having African-American doctors, having African-American chaplains, having people on the team who look like the patient. I think that enhances trust. And also, all of us, whatever our skin color, really showing a sense of true compassion and caring, and just spending time with somebody and really saying, I understand why you might feel that. I understand why you might feel that. And ultimately the decision is yours. I just want to, you know, and staying in the room.
Here's another complicated thing. And I agree completely about racial differences. But here's another issue that unfortunately sometimes DNR translates into we don't need to do this. They're DNR. So there's a lot we can do for people. They can be DNR, but we can still do a lot of care, some of which may be considered aggressive, but we can still do that. And I think it's a huge communication issue. So my dad was in the hospital, 4.5 years before he died. Had, long story short, he had an ileus. They had to put an NG tube in. The surgery took him off the medicine team and took care of him himself because the medicine team was doing nothing. So here I was in the intensive care unit. The intensive care attending comes into me and says, I see your dad's full code. How can you as a palliative care doctor make him full code? I said, because I want to avoid what just almost happened by the medicine team, that he wouldn't have been treated for something that's reversible, right?
Absolutely.
And so, and we'll take this outside. Don't talk in front of my dad like this, But that's so I'm Black. I'm not. I'm an immigrant's daughter. Okay, maybe, but still, I'm not. You would think, and it's the same. I hear this happening. Yes, there are racial issues, but there's just kind of a general.
Yes.
I don't know what is wrong with the health system, but a kind of shortcut to think that there's less that I need to do. People are overwhelmed, not just in COVID, but it's worse in COVID. I understand it, but I think we have to look at some systemic issues too. And so I don't care so much if my patient wants to be a full code, if that's what they want to be. I don't fight with them. I try to work with them about the bigger pictures and, things, if you bring it up soon enough, you have time to kind of work on issues. But I don't know, it's a very complex issue. It's not black and white, that's for sure. It's not simple.
And so much about our communication, which you can do, and we learn how to do in palliative care, but you can do in every medical subspecialty, is to show people that there's always something more we can do. I don't care if we don't have a chemotherapy that's going to work. We've got other things that we can do. There's always something more to do until a person's final breath. And we have to make that, and people listen to that message. When people really, really hear that message and believe you, then there's this trust. That is one important way to establish trust that I think is something we've got to teach all of our doctors, not just our palliative care. And again, I'm all of our healthcare practitioners is just how important it is to really let patients know that we will always be trying to do everything possible that we can for you.
Exactly.
Well, we certainly train spiritual caregivers to understand that DNR doesn't mean let them die under any circumstances. It's very targeted to specific things they don't want, and you may even do surgery if it's palliative and it's going to reduce pain. There's all kinds of ways that we have misconceptions, I think, about what a DNR means.
And you can reverse it at any time. That's the thing.
Absolutely.
It's not like, a colleague of mine tattooed it on her chest. she was a nurse. Okay, that's a little extreme, but you can't. You can't.
But like the daughter in Extremis who says it feels like taking my mother off life support is murdering her, and so much just basic education needs to take place. To be as compassionate as we want to be.
And we also have to really understand the experience of the healthcare providers. I mean, I think that we need to have some compassion also for the experience of being in a situation where you feel that you are torturing a body, where there has been a communication breakdown of some sort. It's not only just because of communication breakdown. Sometimes families are such that the decisions are going to be full court press, no matter what conversations happen. And there is an experience that can be very scarring for healthcare teams to continue to prolong a life that doesn't feel like it's really bringing benefit. And that I think we have to be able to process as healthcare teams, whether it's through Schwartz rounds or it's through some kind of reflective experience on the wards, so that we can process it and not then extrapolate it to every other case that's going to come our way. There will be those difficult cases. They will be scarring. They may make you upset. They may make you err towards this implicit bias of, oh, that person's just going to want that, and I don't want to invest any energy and time with them. If we can process those moments and acknowledge the pain of having those kinds of situations, we can then move forward again and with an open mind towards every patient in the future.
Thank you. Our small groups are closing and everybody's popping back. I'd like to invite all of you to unmute and to share what you've been talking about in your small groups. And if you have questions for Dr. Puchalski or Dr. Zitter, to ask your questions. So opening the floor.
You can also use the chat if you want to pose questions or bring in reflections.
Yes. Let me ask too, just to remind you, this is all being recorded on Facebook, and our IASC Facebook page will have all of the slides, but we will talk about whether they're proprietary or not and whether we can get them to you as a document. But everything is recorded on Facebook.
I see a question in the chat box about working with pediatric chaplains. Thank you for that question. So there is a whole network of pediatric chaplains, happy to connect you with them. But in terms of some of the work we're doing with ISPEC, we are doing we have a sort of an ISPEC core curriculum. We're developing an ISPEC pediatric curriculum now, so working very closely with pediatric chaplains on that, as well as an ISPEC faith community leader program as well. But there is a very strong group and a subgroup within the Association of Clinical Pastoral Education that are pediatric chaplains. And you can email me and happy to connect you with all of those people.
So any reflections or questions are welcome at this point.
Yeah.
Sure. Michelle.
I'm Michelle Levensmack, and I'm a seminarian at Candler. I'm also a 30-year RN with background primarily in critical care, ER, and ICU. But I have done a stint in hospice as well. And I'm a Unitarian Universalist. And so my question to Dr. Zitter has to do with, conversely, the patients who will say, or patients or family, who will say, I'm atheist. I don't use that language. That doesn't have meaning for me. How do you address that? How do you address the spirituality that I believe is there, but is wrought with perhaps pain or trauma or whatever in the settings that you are in?
So I think a real part of the definition is a really broad-based definition of spirituality. And I noticed a lot of our examples, we were talking about religion in our small group, but religious beliefs. But We worked very hard to base spirituality around a search for meaning and purpose and a sense of transcendence. And then the connectedness to the significant or sacred, however you understand that. That's why in that definition, this was done by consensus conference, and there was a huge, there's always a debate, but there's a huge debate even about the word sacred. So we included significant, the things that are significant to people. So that's number one. And everybody, atheists have a sense of spirituality. People who are religious might not find their spirituality within their religion, their organized religion. It may be broader nature, other ways. So it's very important that we listen to those broad conversations. We did modify the FICA tool many years ago, not just asking about, are you spiritual, but the second question is, what gives your life meaning? Sometimes those two things connect, sometimes they don't. So if someone doesn't relate to the word spiritual, because that can still be kind of laden with religion in some cultures, though less so these days, but then still asking about that sense of meaning. And usually within that context, that sense of something outside oneself does come up, or deeply within. Does that answer your question? But it's a great question. I'm happy you brought it up.
So I'd like to add something, if I may. So my name's Jane, and I was fortunate enough to find myself in the same breakout room with Michelle. I too am a Unitarian Universalist, so that was quite the coincidence. And but I'm a spiritual director, which means that I see people mostly one-on-one, right? And like Michelle, one of the things we have in common is to find that bridging language for people who clearly have a strong sense of spirituality, but who do not name it in that way. And also as a Unitarian Universalist, I'll say that, my experience has been perhaps a little different from Michelle's, and perhaps that also has to do with living in the North. I'm in Massachusetts. That people will deny that they have spiritual lives, whereas I see them full of a sense of wonder and gratitude. And so, again, helping people language and open. I was struck by Dr. Zitter's, description of the moment of her opening, her heart opening and breaking, if you will. And so those moments that can be created by finding a language that allows people to open and not be so defensive against something that's often been hurtful. I'm not quite sure what my question is in there, but I welcome any response.
This is a very rich conversation, and thank you for all the words. I want to connect this conversation with the issue of miracle. I think a part of the challenge when we face families, patients, talking about their belief in terms of miracle. I have encountered quite a number of times when in the beginning, the patient family, their language of miracle was focusing on physical healing or the cure of the disease. But then as chaplains interact with reviewing possible things, impossible things, limitations of life, potential of life, and gradually they are spiritually opened up to the areas where they can call other things miraculous also. And that's one thing. And also, so this change, spiritual organic change that may happen in end of life, that's one thing I'm very interested in or appreciating, witnessing. And another thing is I just keep remembering this particular family who told me that the miracle conversation might be their processing of grief. That one family said, we don't need you guys come one after another coming into our house and say, she's dying, like we know that, And then in the meantime, in the team meeting, we were talking about this family saying, they are talking about miracle, they are in denial. That kind of language I heard. So after hearing that in the team meeting, I was struck by these daughters sharing of their experience, saying, we all know that she's dying, but we are not ready. We are already missing her. And we are praying for a miracle. And that was really wonderful way she really opened my eyes, like, wow. So I think, what do you think, doctors? When we face miracle talk, our understanding might be one-dimensional, like, yes, physically curable, or no, it's not possible. Maybe in between, maybe.
Well, no, I think one of the really important things that I've learned over the years is I'm praying for a miracle too. I am praying right along with this family for a miracle. And I have no problem saying it. The thing that I think the decoupling that we need to do is the assumption that praying for a miracle means continue life support, continue the ventilator. It's a ripe area for future conversation, but we're all praying for a miracle. And there's so many miracles that could happen. And I think we need to talk about those miracles. And once you start to talk about what the miracles are that could happen in a particular situation, and people are smart, people understand, however faith-based they are, they understand what's happening to their body. And so if we talk about miracles, and we're talking about all the things that we could hope for and that are realistic, there's this almost unspoken understanding of where things are and what the medical prognosis is that comes out of that. So I think praying for a miracle is something that the physician and healthcare team should be doing right along with the patients, and then maybe kind of talking about what that actually means.
Hi, everyone. My name is Edward Benyate. I'm from Chicago. One of the things that I want to comment here as I'm listening to everyone's comments and responses is when language surfaces or cultural aspects, spiritual aspects surfaces in the language that's organic to any community, that there is a potential of creating a split, a separation. And when I hear, for example, since the recent comment is regarding miracle or hoping for a miracle or languages, however, even if they don't use that term, but there's when there is culture that surfaces up, that there is this potential of splitting with the team and strong reactions. And part of why I raised that is because part of the consequences of that splitting is curiosity is impacted, communication is affected drastically, and then there is no sharing, engaging in communication or the curiosity of the other that really impacts how we accompany a human being and understand how we care for this human being wherever stage they're at. So I wanted to highlight that piece as well.
Absolutely. Curiosity and humility, they just go like this, and they're all important pieces that we need to bring.
I have a question. You made this interesting remark that you are talking, Jessica, to the converted. And I think, yes, that's interesting. How would you both say, is it accepted within the medical community to talk about spirituality? I mean, we are so much in the discourse that we think it's normal to talk about spirituality. And I'm actually married to a medical doctor, and he's very open to spirituality, but he says in his daily work, they would never, ever talk about it in the interdisciplinary team, for example. So I really wonder, like both of you, how would you say, is it accepted within the medical community, what you work on?
So, I've been doing this a long time, so I have a kind of different view. I look at progress. So relative to, the early 90s, I think it's more accepted, right? Is it as accepted as I would hope it to be? No, but there's always sort of So you have to take spirituality, and then you have to take these other things that are also not equally accepted. So the humanities,
yes.
Listening to the whole story of the person, whole person care, all these various things get pushed to the side in a time crunch. So then it's, now obviously if I have a patient that comes into the office with chest pain radiating up the jaw, all the classic symptoms, at that point I'm going to gear into dealing with that. But, when, you always have to make those decisions. But I think we tend to, when stressed, we tend to go to what we're really trained to do, which is often the physical. But there's an underlying thing is I think that's why we're so interested in training people around spiritual care, things that are that we're not really trained in, we're also nervous about. So I think there's a lot of studies that have shown that while people believe in surveys that it's important, increasing numbers of healthcare professionals in surveys are saying, yes, this is an important element. What they cite is lack of role models, lack of examples in their setting, money, and time. So when pressed for time, as visits are getting shorter, as things, so I think part of our work and even trying to put something in the electronic health record, they'll make it easy for them to fill out. Will it be as rich a discussion as I've heard from some of you today? Probably not, but at least it's an attention to. So I guess my answer is I've seen tremendous improvements here and in other parts of the world relative to where it's been, but there's a lot more so much more that we all need to do to make it just really a standard and also more presence, the way that we really approach people and accompany them in their suffering and listen with curiosity. That is certainly an area that I think we have to develop more and change our healthcare systems around to make that a priority.
Yeah, Sue and has raised her hand. Sue, do you want to make a question or a comment?
Yeah, thank you. This has been so rich, and this is a discussion in our small group. And I've been involved with work that Christina's been doing with ISPEC, and I really respect that kind of education and training. So I want to speak to the formation piece of formation of medical doctors and formation of theological students, and how we begin to have this conversation early on in the studies themselves, right? In the studying process. So just recently, about 3-4 months ago, I partnered with Mount Sinai, the Icahn School of Medicine, and now we have this monthly conversation with theological students and medical students studying a case study together. And it's been such an enriching, insightful conversation as I'm eavesdropping and what people are talking about. I mean, our students have, unless they have medical training, have no idea the way a medical doctor would think about a situation. And it's just so different. And the medical students are saying, what do chaplains do? What do you do anyway? And I'm thinking, this is why we need to have this interprofessional training together. And we're going to also include nurses, nursing students also coming in this time around. And it's been such an impactful way of learning, taking a case study and each profession looking at it differently and learning so much from each other, and starting at the kind of educational level and the formation level. So, I mean, just wanted to just put that out there, and what's being done around this kind of learning and formation and training. So I just thought I would ask that.
Oh, wow. I just have to say, I couldn't agree with you more, that I think that, the interprofessional approach of education is critical. And it is one of the things, obviously, that will make us work systematically better together. But it also does so much to do team building and to build humility. And I think it's critically important. I would say that one thing I have found to be so important in my work is this prayer moment. And I'm going to be honest with you, I'm not likely to go in and pray with a patient on my own. The times that I pray with patients are when I'm with Chaplain Betty Clark, and she starts the prayer. And I think it might be asking too much of physicians to initiate prayer, but I think it's a critically important piece of the relationship. Whether or not again, the healthcare provider is a faith-based person herself. So I think that's one of the many functions that I could see from an interprofessional relationship, that, you know, you should go into the room with the chaplain when the chaplain is coming to see that patient. Figure out if you can get that in once a week so that you can experience that with your patient.
I also, regarding prayer, when I teach my intro course, I make it very clear to our spiritual care students that they should not impose prayer on someone who doesn't want it, and preferably we should follow the patient in asking for it, or to offer, would you like to have a time of prayer? Would you like to do it with you and me, or would you like to pray, or would you like me to pray? And then only pray for what they've been talking about, not what you think they ought to pray for. Prayer is powerful, and it can also do harm. So we have to be very circumspect about not assuming that everyone prays the same way we do, or even whether they want it.
I want to get back to that question about professional development. So we did develop a program called Reflection Rounds, using the CPE, a very modified CPE, Clinical Pastoral Education verbatim, and the students get a chance to reflect on a patient. How were they affected emotionally, spiritually, humanistically? Why did they pick that patient? What moved them about that patient? And it's been a real profound program. We have integrated that at GW as part of their professional development groups, which is a little up in the air right now because of COVID, in ideally the way we do it. We have had over the years chaplains as co-mentors of these groups, which has made a huge difference, I think, in the types of discussions. But even when we haven't had enough chaplains to do all of the groups. So even in the groups where there wasn't a chaplain mentor, the students are just like Max, just like you and I were, they're naturally inclined to want to share at this very sort of deep level. So that's one thing that's been done, and that's been piloted in 18 medical schools. And I know it's continued in those medical schools. That's one. The other is just reminded me of how I developed the course on spirituality and health. I was a second-year medical student, and back then we had this fully interprofessional course. The students from religion department, law, medicine, nursing. We didn't have nursing at that time, but George Mason nearby, a PA program. So we had, and the MD students, and the discussions around very different topics in medicine were profound. So I love that program that you're talking about. I think for us to understand and learn from each other. And then, in terms of prayer, I think that's so complex and it requires so much education. A chaplain colleague of mine once was in a conference following physicians who talked all about the power of prayer. And he says, here I am, a chaplain and a Catholic priest, and the last thing I want to talk to you about is prayer. And then he went on to say that in his encounter with patients, that if someone asks for prayer, he really distinguishes the need at that time. Are they using it to avoid going deeper into whatever discussions were going on? So he really taught me about what you have that I don't have, which is the trained counseling around spiritual issues, and not jumping in and trying to fix with prayer or a ritual, but exploring, and then maybe at the end. So I think we're not trained in leading prayer. So I think it's really important that physicians and nurses understand their boundaries, being present to having the patients say their word, not rejecting them, being open. All of that is good. But I would caution about, I think we have to recognize, and here I probably have a lot of respect for different professional training and how we can come together to meet the needs of the whole. So I love, Jessica, when you say you go in with the chaplain. That's my favorite sort of thing to hear. Like, and wouldn't it be great, the nurse and you and the chaplain, that's I think what would be the ideal.
But I do want to add that I'm so excited about, I want to hear more about what you're doing at George Washington and this program in 18 medical schools. I think it's exciting. I also want to give a view from the trenches, where places that don't have like how do you pronounce it? Gowish. I'm not feeling, and you have obviously the trajectory of time. You've been thinking about this for a lot longer than I have, but I'm right now feeling that we really have some, I'm concerned about the way things are happening on the wards, and I'm really excited to hear about your program. So I want to talk to you more about that.
Yeah. Well, and it's a challenging, it's a historic moment in healthcare right now, because things are changing and they're changing rapidly. And, you know, with telehealth, and that's just one little part. Who knows what's going to happen after this whole pandemic? So we need, all of us in this group right now, we need to make our voices heard for healthcare models. They're going to look different a couple of years from now. So this is the time to start putting in those humanistic pieces, those spiritual pieces, those, you know, the whole person pieces. I think it's really a critical need.
Well, I think it's not coincidence that a lot of this began with the hospice movement, because I know, to take it back much earlier, 1982 or 1981, I took a course as a divinity student at Harvard that was designed exactly to be half med students and half divinity students. And it was one of the most impactful courses that I took in that program. And one of the things that came out of that was talking about a distinction between pain and suffering that I've never forgotten. That in fact, suffering is the meaning that you make of your pain. And people who qualitatively thought that their suffering was greater also would experience their pain to be greater. And so the interconnection between people's own subjectivity and their whole sense of themselves, and not just the mechanics of what causes pain, it does involve all of us. And I wonder if now, too, there's a bridge between all of what we've been talking about today and the field of narrative medicine, which tends to also want to look at the whole person.
Absolutely.
Zipporah has her hand up. Zipporah, are you there?
Hello, can you hear me?
Yes.
Sorry, I don't have a video right now, but I just wanted to say thank you very much for today's sessions. And Christina, I've attended Christina's training some time back, about 2 years ago. So it's very interesting. And I did learn a lot about, you know, as a palliative care doctor, being involved in spiritual care is very important. I just want to say that I heard a lot about miracles and everything. I live in Africa. I'm an African, was born in Africa, and taking care of most of African patients. Our patients believe so much in miracles healing. So even when giving spiritual care and palliative care, we respect their wishes and their desires, and we'll work alongside what they wish for us to help them with, as we give them the spiritual care they need. And one of the things, again, I think was mentioned is, I know that once when I started working in a hospital many years ago as a young doctor, I went to see one of my first elderly patients, and she wouldn't allow me into her house until I said a prayer. And I had never prayed loudly, really, for somebody else except for myself. I was very challenged. It was my first week at the hospital. I had never worked in a hospital before. I was not even trained yet. When I was told, pray for me before you come into my house. I didn't pray because I didn't know how to at that time. The driver who had taken me to the home visit was a very religious person. He prayed. And I can tell you that visit was like one of the best visits I've ever had with a patient. She was so happy. She was 82 years old. The most important thing for her at that particular point of time was prayer. And in Africa, I always say that spirituality and prayer are very interlinked. We don't separate both of them most times. I know that we have a different definition for spirituality, a different definition for religion, but we find that these two go very well hand in hand. So mostly we'll work alongside our patients. If there's a patient who just needs spiritual care, for example, the day I'm talking about, I saw a patient who just wanted me to pray, not to pray for them, but just talk to them about birds and trees and whatever in her garden. And that was the way she was now relating to her maker. So it really depends again with the patient you're seeing, what is their need, how do you meet them at the point of their need. If they ask you to pray for them, I usually say that, what would you like us to pray for them? Let's pray together about it. So that's some of the things that I actually find that in the field, things can be quite challenging. Thank you.
Thank you so much. Thank you, everybody, for all your sharing. And we have more questions in the chat as well, but I fear we have to wrap up at this point and come to an end of this very rich session. We really want to encourage you to come again to the next sessions, public health, psychology, nursing, pastoral care, and so that we can continue our discussion. Thank you so much for being with us. Thank you so much to both the experts who came to Christina Puchalski, Jessica Sitter. It was really so great. And Christina, you talked about the sacredness of encounter. And I feel like we had such a moment together as well, even on Zoom. And so I'm grateful to you all that you joined us for this meeting. Come again next week and see you soon. Thank you so much.
Thank you all. And I've screen shared the dates coming up, and a reminder that if you are a chaplain who is certified by the Board of Chaplaincy Certification of APC, you can use this time for CEUs, self-reported. And those of you who are taking this for a certificate, the next session will be January 12th on public health, and we look forward to seeing all of you, I hope, next week as we continue this conversation. And thanks to Claudia for being our moderator today. And thanks for such an international grouping of people today. This has been a wonderful conversation.
Thank you.
Thank you very much.
Thanks, everybody.
Bye-bye.
Bye-bye.
Thank you so much.
Thank you.
Thank you very much. I enjoyed it.
Bye-bye. Thank you.
Thanks a lot.
Bye. Thank you.
Bye-bye. Thank you.
Claudia, I don't think there's a lot that we have to debrief. We know what we're doing, right?
I think so. Mm-hmm.
This went very well. I really appreciated everybody's comments.
It was so rich. I think we could have gone on for a long time, but I had a feeling we had to finish at some point. But it was so rich. I mean, these two women, they're such great experts.
Yeah. And I loved the way Christine kind of set it up, and then Jessica took it into a more personal reflection about what it's been like for her. And she is just, she's such a lively, engaging speaker. And then our small groups also. So I'm going to stop the Facebook now.